welcome to another edition or episode, or we're going to call it Accreditation TV. Real excited to be bringing these to you here on a routine basis. So we're, I guess, gosh, we've been doing this over 6 months now, every couple of weeks, and we're building quite a library, and we want you to come over and take advantage of that. It's available to anybody for free. So go to our website. If you've probably already been there if you're watching this right now, by the way, but go to the website, mslhealthcare.com, register, and you'll find the library going all the way back to when we started these. And we've actually added some of our podcast episodes from that were called Compliance for the Sake of the Patient, rolled that. We're just kind of merging all of these informational videos and podcasts into one thing we're calling Accreditation TV. So we're excited to see you all here. I want to introduce our guest today. We talked in the last episode about offsite facilities, specifically about the life safety requirements, and we got a lot of good questions and feedback about that. So we wanted to kind of carry forward with that and bring in a couple of other subject matter experts who probably need no introduction, but I'm going to do it anyway. Monica Stone, who's going to bring her clinical perspective to this conversation. As well as maybe throw in a little politics perspective. I don't know. We hadn't talked about it. But, and then Sue McLaughlin, who everybody knows, who's the environment of care, physical environment, emergency management guru of gurus. So thank you both for giving us some time today to do this. And because I always forget, and I say that almost every episode too, to remind our Accreditation Readiness Network members that for CECs, if you need those, you can get those over there in that network on that platform. So with that out of the way, and also the other thing I always forget is, please, if you've got questions, put them in the chat. We'll be happy to answer them if we can. If we don't get to them now, we'll get to them later. So thank you very much for being here, and thank you, ladies, for joining us today. So let's just kind of jump right into it, because we're talking about offsite locations. One of the reasons these are really important if you're a Joint Commission accredited organization, but even if you're a DNV accredited organization, is there's an increased emphasis on offsite locations. And my personal belief is one of the reasons for that is they've kind of been left alone for a long time. And they're becoming an increasingly more important part of the healthcare delivery system, right? I mean, it's more and more outpatient work being done. So let's talk a little bit about, because one of the things I want to talk about is, and I hate to get too specific about one AO, but I do want to talk about, because it is new with Joint Commission this year, where they are adding additional life safety time and they're spending more time going to these facilities, what kinds of things they will be looking for. But let me just start out with, if you're one of the people that are on the call or are watching this live or watching it recorded later, and you've got a whole list of facilities that are a part of your organization, what are the ones that, in your minds, either one of you, that are most likely to be visited by a surveyor?
Okay. Well, it really depends on a couple of things, but the goal is to eventually be visiting all offsite locations that the clinical surveyor visits with the physical environment surveyor. And, this is a staffing situation for the accrediting agencies as well as, the organization. So they're hiring people to, additional life safety surveyors to help out with this process, which incidentally is required of all accrediting organizations now per CMS. So this is something that no matter who accredits you, you're going to see it across the board. But they'll be visiting the same sites that the goal, rather, is to visit all sites that the clinical surveyor visits. It's not necessarily going to be at the same time, but to get to all sites. Now, I think that'll be variable, and in a little bit we'll be talking about priorities. But, as the accrediting agencies staff up to do this, it's going to take a little time, and they're going to work off a priority list.
Yeah, I would say if I had a preference, I would not want them to be at the same time. But I mean, There's two sides of that coin, right? There's limited resources in these
Exactly.
organizations, right? So, or these
Exactly.
sites. So, Monica, I'm sorry, were you about to say something?
Just that, from the clinical surveyor perspective, I think how they select which ambulatory sites to go to or clinic sites to go to, off sites to go to, I should say, is based on what kind of services they offer. So they're going to, if they have to prioritize, they're going to hit those locations that have the higher risk services that are being offered. Anything with high level disinfection, anything that has any kind of sedation, significant medication administration locations. So things that they know they need to take a look at where there might be higher infection control risk or specialty populations that they want to ensure that your processes are in place to take
Mhm.
care of them appropriately.
Yeah,
Sure.
yeah, that makes perfect sense. So, you know, assuming that the list is going to start risk based, and I would expect that. I think there'll probably be a fair number of. Well, I don't know if I were going out, and I've done these right as a pretend surveyor. I say I'm not really a surveyor, but I play one on TV. I will look at that list and pick one that's kind of far away on purpose,
Hmm.
believing that that's probably a high likelihood that it never gets visited.
Hmm.
But I don't know if that will play out. Oh, I mean, time constraints are going to be critical here too. But what kinds of things, from a physical environment? So I'll start with you. Do you think they're going to be looking for? I mean, we talked about life safety stuff in the last, but feel free to talk about it. But beyond like just the life safety components, what are the things you think they'll be looking for?
Okay. Well, first of all, I want to clarify one thing that was out publicly for a while, and that was that the surveyors were going to require life safety drawings at business occupancies, and that has since been rescinded. So, what they are going to do um, is um, expect that at the business occupancy sites that the staff are knowledgeable about their exit routes and any smoke barriers or anything that they may have and so forth. Now, this is for business occupancies only. The ambulatory care, of course, does have to have the life safety drawings. But in the business occupancies, the question about staff knowledge and some of that is going to be a little challenging to these facilities. And so one thing that we as a team at MSL have decided to recommend is, most everybody has posted their uh, fire exit paths, the drawings showing those fire exit paths, and to just make highlight on there, those exit paths, uh, any barriers that are fire or smoke rated. For example, if you're separated from a totally different occupancy and things like that, that those can be just indicated on those exit diagrams, and then the staff just need to be instructed to point any surveyors to those exit drawings. But beyond that, what are they going to be looking at? They're going to be looking at general life safety code compliance. So, they're going to be looking at sprinkler heads, exit signs, exiting, but they can also be looking at uh, electrical panels, electrical outlets, junction boxes, storage rooms, fire extinguishers, emergency lighting, all of that kind of stuff. They may do a little bit of work above the ceiling, particularly they will in ambulatory healthcare occupancies. Probably not so much in business, but don't rule that out completely. And so those kind of things are the general observation things. But they are also going to be, just looking at documentation of the maintenance, testing, and inspection of the features of fire protection. Now, there's some debate about that because in my experience, most organizations have that information for their offsites at the main hospital, and um, some of them do not. Some of them they're on site, but the people there need to know where that information is kept and whether the surveyors review it at the offsite location or if they review it at the uh, main hospital location. I don't think that really matters, but people need to know that it is available and where it is available um, for use. Now, other things that they can be looking at is the maintenance, testing, and inspection of your medical equipment. They can be looking at your gas cylinders and the policy for that, which typically comes out of the centralized location. Safety data sheets. Um, there are always chemicals in the EVS closets at the off sites. Often they are a vendor that is coming in and doing the environmental services stuff. And they don't know what's there. They don't have them on the chemical inventory. They don't have SDSs. That sort of thing can really get problematic. Security, if security issues, then that's going to vary from organization to organization. Um, who signs the manifests for the regulated medical waste disposal? That's a real interesting question. And most people, we've seen a lot of problems with that over time. Also, they'll be looking at fire and emergency drills. So having those records there is important. Just as if it were a hospital, those records need to be maintained.
Yeah. One thing I would add, if you don't mind, and then I want
Of
to get to
course.
Monica, is those fire evacuation maps. Life safety drawings are not required in these business occupancies. That's true, but people tend to think, well, life safety drawing, I need to have a CAD drawn, P approved draw, and that is true for the hospital and ambulatory healthcare. But you can create an informative life safety diagram by taking one of those drawings, a floor plan that you use for evacuation routes. And if you've got any kind of features of fire protection, maybe there's a storage room that's protected, you can just take a highlighter
Yeah,
and create that.
exactly.
Did that for years before we had CAD and had some of them. I actually used to take it, scan it, and do it in Photoshop. I was really, really technically savvy back in the 90s. Um, but it looked a lot cleaner. But that's something that can be done to provide a little, because it's easier to maintain something when you understand where those features are. So
Hmm.
just a bonus tip. So let's talk, Monica, from a clinical perspective, when you guys go out
Hmm.
and do these offsites, what are some of the things you're looking for in particular?
Yeah. So I think it's important to remind everyone that any of the hospital standards can apply to these locations. So, I mean, it's not like you can exclude any of them. If it's occurring in an offsite location, it falls, and you're under the hospital licensure, the same standards apply.
Right.
But I do think that there are some areas that are really targeted in the offsites, including just the basic ones, like how do you identify a patient, and doing that consistently. You'd be surprised at how many times it isn't consistent with the hospital policy. So make sure that there are, just that very first step, identifying the patient. Record security is a big deal in the offsite locations, particularly if they're not on your electronic medical record and they have a lot of paper records around. Making sure that those documents are kept locked and secured overnight, where there isn't inadvertent access, and also the
Going back to
protect
I'm sorry about
under.
don't mean to interrupt, but going back to Sue's comment about off contracted EVS at night,
Mhm.
do they have access to medical records or not? That's a really,
Right.
yeah, Sorry.
Absolutely. So we really recommend, if you do have shadow charts of any kind or patient schedules that have information on them, that those are kept under lock and key at night where EVS staff or anyone else can't see them after hours. And make sure that they're not in locations that could get damaged by water, sprinklers or so forth, or not sitting on the floor if you have boxes of storage and so forth. So I'm really paying attention to those records. And then infection control practices, just as in the hospital setting, making sure that all your cleaning practices are in place, that staff understand their wet times and what needs to be cleaned, how you identify a clinic exam room that's been cleaned versus dirty, so you're not placing a patient in an unclean room. Monitoring your hand hygiene, making sure that staff really you have the appropriate sanitizers and that they're following the guidelines. Supply management is something that often gets a little wonky in the clinic storage in the offsite areas. Patient supplies have to be kept in clean areas separate from other supplies or things that would be considered dirty. So oftentimes, space is a shortage and people like to mix staff belongings, staff supplies, paper supplies, all of that with patient supplies. And there really needs to be a clear distinction with that. And watching the expiration dates on all the supplies in the area and making sure that they're, of course, staying current. Other things they look for, I think, is how are you managing if you're having sick patients walk in, how are you managing infectious disease possibilities? If you have somebody walk in your clinic that's coughing and hacking and sneezing, do you have a process in place to kind of segregate them from the other people in the waiting room to keep them from, potentially spreading something that's infectious in that way? Medication management in the offsite locations. Oftentimes some clinics don't have any medications. Others have considerable amounts that have to be managed in under the same pharmacy standards. For instance, there should be pharmacy oversight over the medication management in the offsite areas. So a monthly inspection, some sort of reporting structure so that pharmacy has oversight over the storage locations and the management of the rotation of stock and so forth. The same labeling requirements for medications and 20 and beyond use date labeling has to be applied, and that's often missed in the offsite locations. So making sure those same standards are applying. So it goes on and on. Mm-hmm. Consents. If you have consents is something else that if you have procedures in your areas that you need to have informed consent for, making sure that those are all completed appropriately, signed, dated, and timed for each one of those procedures.
So
those are the general things.
A procedure, for a non-clinical time, is it like if they're going to remove a mole, it's a dermatology clinic, that's a good procedure, I'm assuming?
Well, organizations typically define what they consider a procedure that requires informed consent. So I would follow those same standards. Okay. It's usually something that's invasive to the patient.
It's funny. I learn something new every time we do one of these. It's kind of cool. Like I never heard the term shadow chart before. It sounds kind of cool. I'm what that is. The backup, electronic record. I don't know what shadow.
A lot of shadow chart. Well, what I mean by shadow chart is if you are pulling, oftentimes in busy clinics, staff will help the physicians along by pulling key documents out of the EMR and putting them in a file so the physician doesn't have to look for them. What the previous visit looked like, what was the last hospitalization record, those kinds of things that will help the physician the provider be more efficient. So then you end up with paper copies of health records that are laying around that you have to then manage. Okay.
See, learned two things new already today. So.
And then I'll just take a minute to point out there are patient population specific things you need to be wary of and watching for in the outlying areas, specifically in any surgical clinic or any clinic that does do things like skin procedures. If you have any kind of surgical instruments, how are they managed? And that whole decentralized instrument management process with the red bins and the pre-cleansed sprays, all of that. And then you get into the hazardous transporting of those, as Sue mentioned, and who can transport those kinds of biohazardous items, and making sure all that is in place.
Yep.
Vaccine storage, particularly in pediatric clinics, making sure that you're following the guidelines for vaccine storage with proper refrigeration and so forth. So all of those types of things that they become, routine, and people don't think of them as being under hospital standards, but they are. So you have to follow the same guidelines.
Yeah. Okay. So, Sue, when you're out surveying, you do a lot more surveying than I do these days. What are kinds of things you're seeing when you go to these sites that people ought to be aware of?
Well, there's quite a variety of things, actually. One of, and I'll just go through my list kind of the most interesting or common findings that I have seen.
Yeah.
And probably one of the things near the top of the list is safety data sheets. When you ask for a safety data sheet for a given chemical that you happen to find in the vendor housekeeper closet, um, people mostly don't have those. And if they do, I have seen hospitals that have a book that's dated from, you know, 20 years ago of SDS sheets. And of course, the one that you're looking for is not there. I have other folks that don't even know that they are on the hospital SDS system. And again, if they do know and they are, they may find that those housekeeping chemicals are not in there. So
Yeah.
a lot of things you have to look at with SDS. And sometimes they'll say, well, here's the book and we can get it on online. And you want to say, get rid of the book from 1990, But
Yeah.
so there's a lot that goes into that SDS sheets. And most times, staff are not really knowledgeable about what it is or where it is or anything else. So that's important. We already talked about the cleaning chemicals quite a bit, and so that's another thing that they have to know, that once they are there and in their closet, they have to do all the things that are required for that chemical on site. Manifest for signing the regulated medical waste disposal. Anybody that any site that disposes of regulated medical waste, and some sites legitimately don't have that, but a lot of them do. You ask that question and you kind of get the deer in the headlights, or anybody who's there can sign for it. And, neither one of those works with the surveyor, because you have to be trained per the DOT requirements if you're going to sign those manifests. So, and sometimes even when you ask about that at the hospital, they haven't even thought about those offsite facilities. So for everyone there has to be one or two, I recommend two people who are DOT requirements, because if there's only one, what happens when that person is off? So that really is something that you need to take a close look at.
And just for the record, it's not a huge lift to learn the DOT requirements.
No, it
Yeah.
is not a huge
Not talking
lift at
about your
all.
egg or something like that. It's like,
Yeah, no, but you do have to have people trained at every site.
yeah.
Anyway, next thing I want to talk about is exit stairs. Typically the exit stairs are always marked, but for example, I had an interesting experience with that at one of the sites I visited relatively recently, where they had an exit sign. So I went through the door and I was through this big unfinished area of the building that was filled with machines and stuff and everything else before you got to the marked exit stairs. So it wasn't a clear path to the egress at all. And so just look at the exiting, because sometimes that can be problematic. I've seen obstructed sprinkler heads. One place that was a PE, um, or not PE, a physical therapy gym. They had a big machine with an overhead bar, and that overhead bar was sitting directly under the sprinkler head. So
Yeah.
these are things that, I mean, not unexpectedly, but the people who are typically working in these sites, they don't know to look for all of this stuff.
Yeah.
So
Like, you
it's
know,
important that at some point in time, with environmental tours, you need to hit these sites to see, because people there don't necessarily have um, the knowledge of all
well,
of
there's
this.
a requirement that you do them at least once a year, right? And of course,
Yeah,
that requires no more, but it's still considered
it's
absolutely best practice.
absolutely.
I would think once a year, depending on the scope, size, risk, all the things that Monica laid out a few minutes ago,
Mhm.
would be probably not enough even. So I didn't
Okay.
interrupt, but absolutely.
No. The other thing to look at is the fire extinguisher monthly inspections,
Hmm.
because I've been in sites where they had the tag, the appropriately dated tag for the annual maintenance, but on the monthly inspections, everything was signed out for all year when it was only September, you know? So you have to make sure that everybody understands what they're doing, why they're doing it, and so forth. Um, Exit to a public way. Uh, I have been in, I think most specifically, this happens in infusion centers, freestanding infusion centers. They've got a lot of exit signs on their doors, but some of them go out through grass, or, a little garden or something like that. And many of these people are going out in wheelchairs. That's just not going to work, besides the fact that it's not code compliant. So you have to look at the exiting the public way, and also look at participation in fire drills. You need to look at the fire drill documentation, and that only has to be once a year in business occupancies, but you need to make sure that you've covered all of the people that need to be in participating in that fire drill. And
Yeah,
then
Skip talked a lot about fire drills in the last video, and about making them specific to the site, because unique site has a unique requirement.
right. And again, you may have, while you're only required to do one drill a year, if that only covers half your people, you're going to be better off doing two drills per year, so that you know that everybody is trained. And then the last thing that I want to mention in terms of what do we see at the off sites is issues with staff knowledge. You ask them questions about some of the drills, how would you respond to a fire, so on and so forth, and they can't speak to it.
Mhm.
So the staff knowledge and training is very, very important as well.
Yeah. Well, that's what accreditation TV is all about, honestly.
Right.
And the future of it is to help provide a way for education to be decentralized and available. Yeah, maybe you just gave me an idea. Maybe we want to do some more education that's down at that level. But
Yeah.
you mentioned, some of the trends, and Monica didn't get to see this, but Sue and I just did. The next, for the people who are using Action Planner, the next version of it, we got to see a little preview of the quality dashboards that are coming out, and the ability to surface repeat findings by facility will be really cool for this particular thing, where you're going out, you're rounding, and we're seeing, oh, well, this is happening repetitively at these facilities, and let's zero in on that level of education, or SDSs, or whatever it might be. So I got pretty fired up about that. I'm still pretty fired up about it. So Monica, let's talk about clinical stuff. What are some of the things that you see when you guys
Mhm.
go out and do your thing?
Earlier, well, late last year, I surveyed a place that I ran across something I hadn't run across before. So I think it's worth talking through. And it was in a clinic setting that was seeing oncology patients, and a patient had come in with an indwelling urinary catheter and had excreted prostate seeds, radioactive prostate seeds, into the urinary collection bag. So the clinic had, the physician or whoever had removed the urinary catheter. But then the question was, what do we do with these radioactive seeds that are now in their possession? So it was interesting because at the time, I happened across the catheter, the urinary bag with the radioactive seeds in it, in an exam room that was not, of course, marked anything biohazard, anything radioactive, anything, but they were sitting in there and had been sitting in there for hours waiting for them to determine, what do we do with this? So I think, thinking through those kinds of scenarios, even though they may be rare, you need to know who your resources are to contact, and you need to know what your processes would be to handle them. And it was just kind of a unique situation I came across, but certainly one worth understanding. If you're caring for patients who have and essentially anybody could care for those patients because they can walk in to any clinic. But if you're at a higher likelihood of that, be prepared. I don't know,
Yeah.
Sue, if you have anything to add to the handling of radioactive materials, but it was a unique situation. Mm-hmm.
Yeah, once in a while, I find that in the clinics that I'm looking at, and typically I haven't run into any problems that would be visible to me like that.
Mm-hmm.
But yeah, it's an important thing to look at, and I certainly have been in clinics that are using radioactivity in limited areas, and
Mm-hmm.
yeah, it's got to be signed, it's got to be managed, and all of that.
Mm-hmm.
Yeah,
Yeah.
it's kind of the whole low volume, high risk kind of thing, right?
Right.
I would say, if you geographically you start mapping out your facilities, the likelihood of one of those low volume, high risk things occurring probably goes up exponentially the further you get away from the main hospital or the main emergency department, because people are going to seek care more likely close to
Mhm.
home. I'm just speculating, but it seems
Yeah.
like the weird stuff happens
Mhm.
further out than usual. But any other, you guys have any other things you want to talk about with
One
this?
more thing I just want to mention. Um, we've heard from some of our clinical people that we really need to be looking carefully at medical equipment, which is delivered directly from a vendor or which comes to the hospital and then is shipped to the offsite location, to make sure that that has had all the checks from clinical engineering that it needs to have prior to being put in use. It can't just come off the truck and be used at the site without some inspection and logging it into the system and all of that sort of thing. So be careful of that too.
Yeah.
Mhm.
The other thing I'd like to add to that is cleaning of medical equipment. Who does it?
Good point.
Mhm.
Houses. I mean, that's true in the hospital too, but we're talking about offsites today, but it seems to be a problem everywhere that I go. So anything else, Monica?
Um, I just want to put in another plug for really paying attention to your decentralized instrument management processes. Those tend to not be well thought through in the offsite settings, and specimen management on clinics who collect specimens, any kind of specimens, whether they're throat cultures or blood specimens or tissue specimens from a dermatology clinic, whatever. Really look at your processes for managing those specimens, everything from the collection of those, and if you're placing them in formalin, making sure you have all of the supporting processes in place for that hazardous chemical, and all the way through to the proper labeling procedures, labeling in front of the patient with the right information, to the chain of custody of that specimen and logging it out to the lab or the pickup service that you have, so that you can maintain that chain of custody of the specimen that's required. So
Yeah, I almost asked a little while ago, and I decided not to, about how common we're seeing, or how common it is to see labs in these organizations now.
yeah.
I mean, I know
It's
there's
common.
like there's more draw spaces now than actual real lab. I mean, the old days there were like literally labs, but
Labs.
Mhm.
so
Yeah.
One more thing that I have seen that I think is worth mentioning, and this where I see this most often is at remote physical therapy sites. You ask them about the retrieval or the disposal of regulated medical waste, and they're not drawing blood, they don't deal with that or anything, and so they don't have it. But I go, do you change any dressings?
Mhm.
And then you start going down a different path there too, that yes, you do have medical waste, and yes, it has to be disposed of properly.
Mhm.
yeah,
Mhm.
it's a good point.
Mhm.
It's a good point. Well, we're right about 35 minutes into this thing. So if you guys have anything else you want to cover and talk about?
I think that'll do it for me.
We're still getting information about what's going on in the world of surveys, whether it's DMV or whether it's Joint Commission, what they're doing in 2026. So as we get that information, we'll pass it along. Um, we're glad that you guys gave us some time, both Sue and Monica, and we're glad that the
Mhm.
people watching gave us some of your time today to watch this. We're going to be keeping this going forward here in the next, well, into perpetuity is the plan. Is just to keep doing it. So again, if you're a Accreditation Readiness Network member, one of the things I wanted to mention, in 2026, we decided we were going to start doing the one-on-one calls with your kind of lead consultant. And if you got questions specific to this, item or anything else for that matter, if you want to talk about, what you got concerns about your offsites, then we'll put that on that agenda during that discussion. So, and if you're not an Accreditation Readiness Network member and you want to be, reach out to us on the website. We'll tell you how that all works. So, thank you all very much for your time. If we
Mhm.
didn't get to your questions in the chat, we will do our best to respond via email. So we look forward to hearing from you in the next one. And thank you both. Have a great rest of your day.
You too. Thank you.
Thank you.